Good morning. Today I'll be introducing Ms. Ophelia Dahl, co-founder and director of Partners in Health. It is a privilege and an honor to introduce a woman that embodies the true spirit of service and leadership. Her commitment to service began at a very young age. She first visited the impoverished central Haiti at 18 years old. And since that visit, she has worked relentlessly to bring healthcare to areas that otherwise do not have access. She has continued to live by the principle that everyone, whether poor or rich, deserves the right to have a high standard of medical care. It is precisely this principle that motivated Ms. Dahl to establish Partners in Health in 1987. Partners in Health is a nonprofit organization headquartered right here in Boston that is committed to addressing health inequalities and social injustice globally. Since its creation, Partners in Health has expanded beyond Haiti to other countries such as Peru, Russia, Rwanda, Lesotho, Malawi, and the urban United States. Today, Partners in Health operates over 60 hospitals and health centers in these countries with a staff of more than 12,000 worldwide. Under Ms. Dahl's leadership, Partners in Health has forged groundbreaking successes in treating diseases and promoting healthcare and human rights globally. As a result of her exceptional leadership in the aftermath of the 2010 Haiti earthquake, she was named the Bostonian of the Year. Please join me in welcoming Ms. Ophelia Dahl, class of 1994.
Very much. Thank you. What a lovely introduction. I'm very happy to be here with all of you today. It was I was reminded actually in that lovely introduction about coming here just after the earthquake. And I said last year that returning to Wellesley, even though I only live in Cambridge, is very much like returning home for me. It always feels good to be here. And at that particular time after the earthquake in Haiti, even though it was a tumultuous, difficult time, I was glad to be here at that particular moment, so that I could feel, in some ways, and my colleagues could feel, embraced by this fantastic community. I'm also really delighted and intimidated in just the right way to follow the marvelous Dr. Penn, who, as you know, having heard her talk and lecture this morning, that her experience in the field of global health, particularly women's health, is really has known no bounds, and so it feels very good to be here with you. So what I wanted to do was also to say that I'll probably talk for about 35-40 minutes or so, and then I would love to have a conversation to open it up for questions and to make it more of a discussion. I think, one of the things about talking about the founding and the work of Partners in Health is that it bears discussion. We cover a sort of 25 to 30 years, and it's hard to basically sort of distill it down into a half an hour. So there are many different things that I could talk about. So I hope that as things come up, you'll note them down, and we'll have a sort of a good and robust discussion. So what I thought I would do is I would start early on, not presume that any of you know much about Partners in Health, the healthcare organization for which I work, but just to tell you a little bit about the story, and my story particularly. I work with a lot of different people, but as I was the one invited here, I'll talk about my story. And just to say that when, and it was already alluded to in that lovely introduction, I was about 18 years old, and I had finished my A-levels in the UK. I needed to find out what I wanted to do with my life, and my father encouraged me to go abroad and see a little bit of the world. And through a sort of a bit of luck and fluke, I ended up in rural Haiti, working as a volunteer for an ophthalmic organization, but living in Port-au-Prince in a school for handicapped children. And while I was there, I met many very interesting people. And one of the people that I met pretty early on is a fellow called Paul Farmer, and he had not gone to medical school at that point. And we found that we got on very well. And he really sort of introduced me to the central plateau of Haiti, And it was there really that this story begins. So this is the place that I ended up, and this was taken in about 1984 and 1985, and it's a little village called Cange, and you can't see it from here, or you can't see the actual lake, but these are very barren, very denuded mountains, and here is an enormous lake, and it's a man-made lake, and so all of the people in these surrounding rural villages were actually forced up by this major hydroelectric dam project that was done in the 1950s. And so we were working really with the community of what we call water refugees. And they were sort of, as subsistence farmers, forced off their land up into these really sort of stony, absolutely infertile hillsides. And that's where I ended up. And I'll sort of take you back there at the end a little bit. But as you can see, I think you can see already, I mean, this is not a lush place to end up. And, early on, you could see by walking around that the conditions in which people were living were really, really terrible. This is a very typical house in a rural area of Haiti. And the other thing I want to mention, but we can certainly branch into other areas of the places that Partners in Health works, but this, for those of you, many of you may know, but for me it was absolutely stunning coming from the UK. I flew to Miami, which felt like a long flight to me, and then I flew from Miami to Port-au-Prince, which was kind of like going from here to Washington, D.C. It's really close to the shores of the United States. And these are the kinds of living conditions in the countryside. So you can actually see that these conditions are pretty terrible, with huge amounts of malnutrition. And these, you didn't need to be an expert to sort of be able to react to what I saw in front of my eyes, that the conditions were really, really terrible. And that, you didn't need to do a study to see what was going on. There was absolutely no access to healthcare whatsoever. And it wasn't a case of sort of little access, it was none at all. And people were literally dying in front of us of very treatable diseases. And, as I said, the insight was not a lack of services. The insight was there was nothing at all available. So we went into the community, and this is a picture I took of Paul many years ago. And this was Cange, and you have to take my word for it that this looks very different now. This is all built up, and there's clinics and dormitories and all kinds of things where there was this sort of quite wretched, quite difficult hillside and that sort of thing. But the reason I love this photograph is Paul was learning Creole. We were living in the community, getting to know the population of people that lived there. And one of the things that he told me early on was, let's get out into the community. He was an anthropologist, still is an anthropologist. And so something like ethnography was pretty natural for him to be able to go out into the community, speak to the people in the community. And he encouraged me to do the same. And I though I was uninitiated at the time, I learned from him how important that was. And really what we learned at that point was very, very rich. We were sitting down in people's huts, as you saw, and listening to their story, understanding a lot about things like structural violence, the large-scale political forces and historical forces that kept them impoverished and allowed them to end up that way. I remember fantastically good conversations, good in terms of good for me, good rich, not so good for the people, because they were really recounting a very, very painful and difficult history. One fellow whose name was, I'll never forget, it was Absalom Kohler. And he talked to me about when they had heard about that there was going to be water coming in their valley, taking their land, but they didn't quite believe it, even though they saw all of this construction going on, very big construction. And that when the water started to flood the valley, he had to choose between a pig or a goat or something else to climb up the sort of 800 vertical feet up the hillside. And sitting down and listening to those kinds of stories with people that have been so affected by these kinds of things. And for them, it's the difference between life and death. So it was moving and motivating all at the same time. But I think one of the things that also I kept doing then, and I certainly encourage you to do the same wherever you end up, is that you can't help but compare your own life with their lives. And I think that that's a good thing to do, because I think it helps you to sort of raise your own standards for them, raise their standards for them based on your own life, and apply your own standards for a decent future to theirs. I think that was very, very helpful for me. So doing this, being with a community and actually spending time with them and then acting on their behalf is part of what we call accompaniment at Partners in Health. It's something we started to do early on. And it means different things for different people. And I think, at the same time, we have to be careful. Somebody joked with me the other day. Accompaniment feels so deeply embedded in the DNA of the organization in terms of the proximity, standing, walking shoulder to shoulder with someone as you accompany them through a difficult time in their life. I think it's probably safe to say we've all been accompanied at some point, or we will all need accompaniment. And it's not a sort of an in-out thing. It's not, give someone a pill and then disappear. It's really sort of helping them through this. And we can go into that a bit more if you want during our conversation together. But you have to ask questions, and when the answers are difficult, you can't say that's too complicated and turn away. But that was really what it was about for us. A lot of the time, going in, listening, and finding out from them what it was like to have to walk 5 or 6 miles to get a bit of water, to see your own child die of diarrheal disease when you know that shouldn't happen. You know that there is treatment, both for the water and for the disease itself. I think that a number of times, like NGOs, particularly small, and we were tiny, we weren't formed at that point, but any NGOs don't generally, and this is what I learned early on, don't generally go in and ask a ton of questions. It's a complicated relationship that NGOs can have with the countries in which they're working, certainly with the governments and ministries of health, but even the community itself. A lot of NGOs would sort of go in and say, here's what I think you need, and start working. It's very important to go in and really have conversations with people to see what it is and listen to them and see what it is that is needed. And for us, sort of putting down roots in specific communities. Home visits became a central tenet for us, and they still remain a central tenet. Accompaniment takes place over many, many years. And the other thing that became apparent to us is that, even though Paul was headed to medical school, we started to work with some Haitians. The needs were health needs, but it won't surprise any of you to know that the issue was really poverty, that the people were dying of their poverty. And so when we asked them what they needed, it was not surprising that they said that they needed a clinic, that there was this dearth of medical services, and that what they needed was a clinic. So at that point, it felt somewhat uncomplicated for me. I went back to the UK, started raising money. Paul stayed there for a bit longer and was on his way to medical school. And we just started raising money, £200 here, £300 there, and found some backing in Boston, and then actually started to build that clinic. We built it on this land here, which happened to be church land. We were living with an Haitian Episcopal priest. It was church land, and we didn't really think much about that, but returned to it later and built this first clinic right there on the church land. But the important thing is that we sort of saw what was in front of us. We treated it. We didn't wait until we had all of the money in hand. We didn't wait until we had the perfect design for the clinic. We kind of just got going. That's been a bit important as we've grown. Much more difficult to do when you're a large organization or when you really need infrastructure. But as young people, addressing a problem, listening to the community, and then building it was something that was very important. And this is what it looked like initially. And this was probably 5 or 6 days after it was built. And as you can see, already there was a crowd of people there that were coming for the first time to access services and medical care. And this small crowd became an even larger crowd. And one of the things that we tried to do then is to remove these barriers to service. So what were the things that were getting in the way that people couldn't access medical care, and they all came. But we realized quite soon, based on a survey and also from word of mouth, that even if you build good medical services, even if you build a clinic, there are so many reasons that people actually can't make it to a clinic. They are too sick, they live too far away, they can't leave their children, they have to make a choice between going to the market or going to the clinic. They're unfamiliar with it, they're frightened. I mean, all of these kinds of things that really do get in the way, even when you build a clinic. And so one of the things that we realized is that we had to make sure that our care then was not only based at a clinic or a hospital or a healthcare facility, but it was actually based in the community itself. And so then we started training local people, and this is actually not Haiti at all, but Lesotho in the mountains in a country in southern Africa. But I like this shot so much because it gives the impression of actually what community health workers have to do in order to get to people's houses, particularly in rural areas. They walk long distances to go and be with people and see people. But this is really the accompaniment piece, and it sort of sounds a little bit fancy in a way, the whole notion of accompaniment, but it's really not. It feels more, as I said earlier, more like the bedrock of what we do. And I think that having people in the community who understand the obstacles and difficulties that people face themselves makes a big difference as well. And I know from the kinds of medical care that has been delivered by these community health workers, it's made a huge difference. One of the things that I've seen actually is that, and a colleague of mine reminds us of this, that often it's like the emphasis is on community health worker, when actually we sort of think about it as community health worker. And then the other day, as I was thinking about the whole issue of compensating these people, training them and compensating for the work, it's actually community health worker. Because some of these arguments that have been posed along the way over the last 15 years or so that we've been doing this work, and I want to be clear that there are other organizations, many organizations that are doing this kind of work, but advocating for people to insist that actually you compensate them for their work, especially poor people. Volunteering is great. I should do it. But people who are already living on the margin, it's not possible to ask them to volunteer and go and visit people and spend their time doing their work and changing the health outcomes. So that chief important part of our work, compensating these people for their labor and training them, is really important. And then, one of the things that I wanted to show in this is that just other community health workers, this is a community health worker spending time with a young boy and his family there, and he's getting treatment. So it's just wanted to show you a couple more slides and pictures of folks sitting down with other people. If you feel unwell and if you are spending a lot of time alone, as many of these people are, cut off in communities, having somebody come regularly from your community and visit you and speak to you will also do wonders for all kinds of care. And this one is back in Haiti. Back to that kid again, one of the things I want to talk about it, that the important aspects for us is addressing what we call the social determinants of disease. So, you can provide a clinic and you can provide care and you can start removing barriers and you can remove fees for services and you can go into the community and you can, train community health workers, but unless you also address the social determinants of disease, it's going to be very, very difficult to do this because as I mentioned before, the poverty in which they're forced to live. So it was, we worked with a couple of, still work with many doctors from this country who go and spend time in other countries in which we work. And I remember this young fellow, Evan, who had finished medical school at Harvard and had done his training, and he had spent time before he went to medical school actually in Port-au-Prince as a musician teaching kids, but he came back as a doctor and he went back into community, spoke Creole, and he was there, and he called me after the first couple of days of doing this work, and he said, you've been trained at a great institution, you think that you have all of the tools, you have a shelf filled with antibiotics, everything you could possibly want, and the patients come in and you say, what ails you? And a woman says, my children have nothing to eat, or there's no roof over my head, or I can't send my kids to school, or there's, any one of those kinds of things that feels, for a doctor, deeply, deeply disempowering if you can't fix some of these core root issues, if you like. Now, many doctors in many countries in the developing world don't even have access to the basic tools like antibiotics and stethoscopes and tests and that sort of thing. So that's another degree of awfulness that we can talk about. But even when you have the tools, making sure that being able to address those issues, that those kinds of things can fit onto a prescription pad is important. Now, it's a good conversation to have about whether that's mission creep for an NGO. But for us, it really felt as though we had no option. And we've had long conversations recently about forming partnerships with NGOs who could focus on housing. But if your children are dying of starvation, you have to make sure that you can address food security issues. So our mission stayed the same, but I guess the platform became bigger and bigger. I think, as you probably know, or certainly will know when you finish this course, this winter session, that a lot of the funding that tends to come for these kinds of issues, it tends to be vertical, so that there is funding available for certain things like malaria or like HIV and it's quite difficult when you're working in an environment in which the problems are not really vertical. The problems are really around building a platform in primary care and trying to deliver that, and then making sure you can address the other issues, the social determinants that make sure that people aren't, after you've given them treatment, going to die of diarrheal disease and that sort of thing. I think that building that platform really means addressing the whole plethora of complex diseases. I'm just reminded just thought about this editorial that I read over the holiday period. I don't know who saw it in the New York Times, where it was in the wake of the just terrible violence and the shooting in Newtown. And I think a minister had been asked to comment on that and what it meant to be spiritual at a time like this, and how do you get comfort. And I was just thinking, I don't know why it flashed into my head, but I think I was thinking about accompaniment, and he talked about, in some sort of roundabout way, about accompaniment and mercy. And I think he said that the whole notion of mercy is entering into the chaos of other people's lives. And it really resonated with us. And when I was thinking about the complexity of addressing medical issues, I thought, yeah, you kind of enter into the chaos of other people's lives. And it's complicated. And as other people who have extraordinary experience in this kind of work will tell you, it's often the thing that both keeps you going and makes you feel very tired all at the same time. And so here are another, just looking at this happens to take place in Haiti, and I'm talking mostly about Haiti, and happy to talk about our work in Rwanda and Malawi and Lesotho. But as I said, it's a lot to cram into a relatively small amount of time. Haiti has a cholera epidemic for the first time in its history at the moment. There's water insecurity in this country, massive water insecurity. So you have people lining up to find clean water. This is a different, so this is addressing the food security issues. This is actually something we call a Nurimamba factory, which is a sort of a proteinaceous fat-filled substance that actually can help with acute malnutrition and have amazing results. So this one right here, we started thinking about this early clinic. We built this clinic on church land, and we realized quite soon, when everybody came from not just that particular area, but everyone started coming from other parts of the country, that we would be inundated and not do a very good job if we didn't figure really something else out. But one of the things that we did at the first time, the first one we built, as I said, it was on church land. It was not part of any sort of a public health, a public sector strategy at all. And we realized that if we only built clinics on private land, essentially, we were not doing anything to really bolster the public health system in any country in which we worked. So actually, out of 75 health facilities that we've either sort of built or helped to refurbish in some way. That first clinic you saw is the only one that is actually on private land. And we literally just sort of drove around with our Haitian colleagues, and we went around to some of the public facilities. And you saw, even after a week, how bustling our clinic was that we had built there. And this is a public clinic. And I don't know how many of you have visited public clinics in countries in the developing world, but this is actually quite common, usually because the service is not very good. It's sometimes the only service is a fee for service, which acts as a massive barrier for many people, even if it's a tiny fee. There's no tools in there. The staff are often undertrained and desperately underpaid. So, you know, this was a site that we were used to, so we, you know, this is what we saw when we drove around, and one of the things that we really focused on was building facilities that were reasonable to build, and I mean really reasonable to build in terms of how much they cost. But this is a clinic we built quite nearby with the public sector. So we joined in with the local, the district ministers of health and or district health commissioners, and then we also started to work with national governments as well, because we really didn't want to build that kind of a parallel structure. If you really believe, as I'm sure most people here do, that healthcare is a human right, the only group that can confer rights upon a population is a government. So, you know, and an NGO is always vulnerable. We subsist because of other people's generosity. And so we realized that actually we'd have to change our strategy a bit and work, however difficult, work with the public sector to try to help rebuild it. So from that moment on, we purchased the land and then gave it back to the government, or we purchased it from people if they were selling it to us, and gave it to the government, have MOUs with the ministries of health. And then we built these kinds of clinics and things. And then Paul is a frustrated landscape gardener, so every single place that we've designed recently, there's always some beautiful landscape in it. And he believes very, very strongly that, you know, that building dignified places for people who are ill is extremely important. And it's not, as I said, expensive. Often these, you know, people will lob things at you all the time about it's not possible, it's too expensive, it's too complicated. And really, you need some plants and you know, he always puts a water feature. We now joke with him because our board of trustees will often say things like, we don't need a rock and water feature in the middle of a clinic. And he said, yes, you do. And these, you can't really see it, but this is a bench, and it's open so that it, you know, to help with infection control as people are waiting and that kind of thing. But it has a beautiful shade, and people can sit and wait in a dignified way. These are important things to think about as we were sort of going along. So jumping to the next slide, this is really the model of care, if you like, that we try to operate with. The care is community-based, so it's based in the community with the people that we're working with, and you know, whether they're community health workers who are working in the community, but that feeds into a health center. So you can give care, you can give good care in the community. We should do it here too. And if you actually can treat many, many, many chronic diseases like diabetes and mental illness and HIV, the care is actually not only cheaper in the home, it's actually better in the home. There are some things you should only do at clinics and some things you should only do at hospitals. But our health system has been a place where people get treated in emergency rooms. If we could base that in the community, feed into a health center, and then it should feed up into a hospital in which you can do things like complicated surgeries and all of that sort of thing, and have, of course, access to, for women who need modern obstetrics and that sort of thing, amongst other things. And that's really that's the model. It's not a complicated model. This is a picture of a hospital that we all built recently in northern Rwanda, on the border of Uganda, and it's in a place called Butaro, and it was built pretty quickly, and again for a few $1 million. I mean, you try and put a bathroom onto a hospital in this country, and you're almost at a few $1 million, right? I mean, so it was built well, and it was designed well. It was designed with a group here called MASS, which is some architectural students who came to a talk that Paul gave, and they said, how can architects get involved? And they started their own NGO, and they went and worked and trained Rwandans, and this beautiful hospital. I joke with Paul that it looks like a villa in Tuscany almost. So, any talk he puts in this beautiful hospital. So, as I said, these are different places. So it really doesn't matter whether this is Lesotho or Boston or Haiti or anything else. This is a very good system to have in place, and in doing so, you can build capacity and really treat some very complex diseases like drug-resistant tuberculosis is something that we treated using this model of care in the community. It's particularly good if the disease that you're treating is infectious. So one of the things that I just want to mention here as well is that, a lot of the time you will hear, I'm sure, along the way that things are too complicated to achieve. You won't often hear them in this country, in our lovely settings. You will often hear them if you go to other places and try to enact things. But I think in some ways, without wanting to be too controversial, that often is a code for meaning sort of too poor, I think. As I said, going back to applying our own high standards to other people's lives to get things done is a very good, I think, a good lesson to live by, because you will hear this a lot wherever you go. I mean, it happens here. It's too complicated to provide healthcare to people here, especially if they're poor. One of the things that I realized actually that did any of you here know he's a physician and a writer, Atul Gawande? Has anyone heard of Atul? So he works here in Boston. He's a wonderful fellow who's been addressing some of these things, and he wrote an article called Hotspotters in the New Yorker a few months ago. A lot of the burden, the expense, is actually by a small group of people who are poor. This doesn't surprise any of us. And so he talked about actually the possibility of doing care in the community. But he also talked about how important it is to, there are a lot of health statistics around, and you will hear some of these if you haven't already heard them, around if you hear that a country, a poor country has a great vaccination coverage rate, say of 90%, you'd say, wow, that's pretty fantastic. It is pretty fantastic in many ways. But that 10% of the population that are not being vaccinated are the same 10% everywhere, which is the poorest of the poor. And that's really, in some ways, the challenge that we and others face. How do you get to those people who will always be neglected, who will always present with the most difficult problems? So I'm just saying this to sort of put it in there and just make sure that as you go on and do whatever you do, and I realized actually that there are people in here who are mathematicians and linguists and German language scholars and English literature scholars. It's fantastic to see so many people in here with all of the different interests, interested in global affairs. So I'm delighted about that. Anyway, so here we are with this not very complicated model. And I wanted to show this one as well. It's, I think, important to show some stories. This is a young girl who's 12. Her name is Pulani, and this is Lesotho. And the doctor who's treating her is a woman called Hind Sati, and she's been working with us for some time. She's actually in Boston at the moment, born in the Sudan, and now lives in Lesotho. And she is a fantastically talented and well-trained expert on drug-resistant tuberculosis. Lesotho has the highest per capita number of orphans in the world, mostly because of its desperate poverty nestled into South Africa, with HIV and TB together acting as a sort of twin nightmare. And this is a young girl with multi-drug resistant tuberculosis. And this is literally 3 months afterwards, 3 to 6 months afterwards. And what does she want to do? Her parents getting ready to bury her. And you provide the drugs and you make sure, she spent some time obviously in hospital as well, but there is treatment for drug-resistant tuberculosis. And then she is treated in her home as well by community health workers. And then what does she want to do? She wants to do what any one of us would want to do. She wants to go to school. and have a decent life. So these are the kinds of, things that we're faced with, and it is one patient at a time. It's also thinking about the bigger picture of this, of course. And some of what we've been able to do over time is to really think about not just treating one patient at a time. Take those patients. When we first started treating patients in Peru back in the 90s, and we really kind of happened upon this particular epidemic. We were working there, and I think we had saved about $30,000 in the early 90s to do a water project. The place in which these communities were living on the outskirts of Lima, they had terrible diarrheal disease, and we found out that the water pipes, the sewage water pipe was on top of the water pipe. So we're going to replace that pipe. And while we were there, both Jim Kim and Paul Farmer, we were working with the reason we were down there is we were invited by Father Jack Rusin, with whom Paul had lived while he was at medical school here. He'd lived in a rectory in Roxbury, free housing, and had gone to medical school. So he was close to all of the folks at this rectory. Father Jack went down to Lima. So he wanted to join the Society of St. James, and he was sent to Lima. When he was down there, he invited us down and said, you guys should come and see this. So we did, saw this community, different kind of refugees, and with more infrastructure in the community, but still bad. So we were going to replace the water pipe. And Father Jack got sick, really sick. And he flew back to the Brigham, and Paul and Jim are infectious disease doctors, and Father Jack died. And we realized that he had drug-resistant tuberculosis. And so both Jim and Paul said, well, if Jack has it, healthy Jack has it, think about how many people in that community have drug-resistant tuberculosis. So if we got TB, which because we're so healthy, would be very unlikely, but if we got TB, we would be treated, and we would likely respond to the antibiotics. Once you get so sick that you are not responding to the antibiotics, the first-line antibiotics, then it becomes very complicated. Interestingly, a lot of middle-income countries have drug-resistant tuberculosis. Not actually the poorest countries often with, I like it when I see some of you nodding, like, yeah, I know this. And that's because some people have been treated to some extent. So they're not so poor that they couldn't buy antibiotics, but either once they start to feel a bit better, or more importantly, they can't afford the 2 years of antibiotics or the expensive set, so it becomes resistant over time. And it's a very complicated to treat disease, but certainly not impossible, as you can see. You just need to make sure that you are able to test for drug sensitivity and give the antibiotics well. So this is what happened in Peru. And it wasn't that we set out as a group to say, let's take on this specific disease. But I think, and the similar thing happened as we started treating in HIV. I landed in Port-au-Prince in 1983. And, this was just at the dawn of the HIV epidemic. And I remember my dad writing to me from England and saying, are you okay? I've heard that there's some virus, we don't know, and they don't know what it is, but it's connected to Haiti in some way. And I said, no, I'm fine. And we started seeing the first patients then. I didn't, I'm not a doctor, but Paul did and his colleagues did in Haiti. So it was an interesting time to be there. But then to realize that treatment became, as antiretroviral treatment became available, it was used in this country. Extraordinary group of activists from places like ACT UP, a lot of gay men in America who did the most astounding advocacy around this and changed policy, and ART became available. And then, of course, it became this very difficult question. It's like, but if African people are dying of HIV, we've already treated the people in this country. How do you make sure that there's equal access, that this can happen there? So we started treating with other groups HIV. But it's really just to say, because I could go on in all kinds of different directions, it's really just to say that if you, as in Peru, we went there with one specific idea. If actually the problem is something else, you have to address that problem. We never changed the water pipe. We actually addressed the MDR-TB. That was a bigger problem, and it was complicated because we had to work with the government. We had to work with the Peruvian government who said, there's no drug-resistant tuberculosis problem here, don't worry yourselves. So that, all of the skills around cajoling and wooing a Ministry of Health that did not want help was really, really complicated and in the end very rewarding. You also had the WHO suggesting that a cure rate of around 40-something% was okay. So it's a long and good and rich story around this sort of thing. And I'm gonna start to wrap up. But this is another patient. This one in Haiti. Joseph Juran is his name, and his mum brought him in looking like this, dying of HIV. Again, the Haitian doctors saw him, and we had at this point access to ART, and he was put on ART. And after he got better, or started to get better, he went home, and then his community health worker came to see him. And here's a very different looking mom and a very different looking Joseph Juran. And what did he want to do? He wanted a job. When people feel better, they want to learn to read and earn a living. And so he became a community health worker himself. Very effective if you've also, battled the disease yourself. You know what it's like to have those side effects. You know what it is to feel so wretched. And then again, sort of, back to some of the things that you have to address. And I confess that Partners in Health doesn't address all of the social determinants of disease particularly well. We try to rebuild houses, but the tiny amount that we're really able to address it's small. And we haven't done a good enough job of finding partners who can help. But if you're a woman in Malawi whose hovel is supposed to count for a house or a home, and you have these children, that this is not a big project. Someone should be doing it. Again, I just wanted to show a couple of pictures. Someone said to me once, do show some before and after pictures. This is in Rwanda in a place called Rwanda. It's the hospital. It was a big district hospital, probably built in 1920, very, very well built, in a little mining community, a copper mining community. And it looked like this. It was just abandoned and empty. There was no one there. And then slowly over time, I'm not sure this is the greatest after picture, but it was rebuilt, and the Rwandan government helped to chip in there as well. And again, this was the pediatric ward, or so-called pediatric ward. I took this picture probably in 2004 or 5, and then we were able to sort of rebuild it and work with others, and it sort of makes a difference what a place looks like. And this, I was in Rwanda in July, and we opened this. Actually this is part of that lovely new hospital I showed you, and it's in Butaro. But this ward is a cancer treatment center. As part of that hospital. And I wish we had patients in here because it's full, I know. But one of the things that we saw happening was that once you start to build a platform of primary care and address some of these needs, people start to live longer, and they also get other diseases that are associated with living longer. And sometimes that is cancer. And of course, there's also other kinds of cancers that affect kids. And it was very distressing for the doctors to find, when this hospital was built, many people coming from afar with children and themselves suffering from cancer. So we sort of made a partnership and an allegiance with the Dana-Farber here and other people. Again, this work brings interesting fellows together. One of them is Jeff Gordon, who's a racing car driver, right? And his foundation helps to fund this too. But to see, as I walked into this in July during the inauguration of it, and all of the beds were filled, and with different kinds of cancers, and to see all of these people getting treatment. And again, people will say, you can't provide chemotherapy to people in developing countries. It's too complicated. It's too expensive. Well, you can. You absolutely can, and we absolutely should. And we should build the capacity in governments to do the same. This is that lovely hospital again in larger font. You can see actually the difference between this amazing lush land and a place like Haiti. So, when I came back to this last slide here, I was brought back from this back to Haiti, and I was talking to some students not very long ago, and I was thinking again about partnerships and how unlikely people are brought in this work together, and how good it feels to see that so many different people who are not physicians at all, but who know that they can come and address these big and complex problems together. And one of the groups that got in touch with us afterwards to form a partnership after the earthquake in Haiti was a a band here called Arcade Fire. Who knows Arcade Fire? Anyone know Arcade Fire? So it's you know, I certainly didn't know it before they approached us, but they're a wonderful group of people, and the connection is that Wynne, who's the lead singer, is a Canadian Haitian. She had actually never been to Haiti. Her parents had left Haiti in the 80s, and she'd grown up in Canada, but she went down to Haiti, and they came here to Carge the first time, the band, and they had a concert, and then they made a video, but they have given us a buck of each one of their tickets for each concert that they've done around the world. And so they've been wonderful, but they came back here, and the difference was, and I had this video, but we couldn't manage it, you know, technologically, I'm afraid, here. But they had done this, and I realized that they were playing right here, but there was a big warehouse that stocks meds, and then there was the physician's dorm here, and there was everything else. And the idea was really to show you the transformation in 20-something years of actually what can happen, not only with the physical piece of this, but also to think about who can join forces in this work and bring about, if you have the imagination to really think about what can be done, I think it's better. This also is a shot from there, which this is the outpatient clinic now, and I don't know if you can see, but it is the mountains from that first slide. It's this right here, and if you see this here, another thing that we've tried to do is to reforest and that sort of thing. So it's a beautiful sight for those of us who have only seen denuded hills over the years, and to be fair, it's the rainy season, but as you can see from here. But these are all new trees. So you know, I think one of the things, just to close, one of the things that I'm often asked, you know, when you're the director of an organization and you rely on other people's generosity, as I said, and they, you know, we have some people, not very many, but some people who give us large amounts of money and have supported us. And then I get approached by people, you know, I'll call them philanthrocapitalists, who've had successful careers doing other things and are very interested in tackling some of these problems. And they will come in often and say, what's the next innovation? I'd like to be attached to that next innovation. You know, tell me what it is. And you know, is it going to be? Often they'll refer to tech things, but in healthcare, is it? You know, is it cancer treatment? Is it this? Is that a new thing? Can I be on the cutting edge of something? And I often will say that, you know, really the innovation, the exciting thing is this delivery piece. Actually, finding ways to deliver healthcare to people who have none in very remote areas in the world, and codifying that model and sort of proving it and bringing other people in and showing others how it's done. That's really that's the most innovative piece of this. That's not been done before on a large scale. And so I have to sort of, you know, bring people into, that is the exciting part of the work, the delivering the healthcare. Building that up, that's the most exciting thing. And they say, yeah. Anyway, can I build that cancer center instead? Which is great, as you can see, we need a cancer center. But it's a very interesting human trait to want to be involved in something that wouldn't have happened if it wasn't for them. And I don't mean to denigrate it. I think it's an important human trait that allows people to be ambitious and get new things done. But it's an interesting conundrum if you're trying to actually get people engrossed in a movement around really building platforms of healthcare. So I would love to open this up and hear some of what you think and anything you'd like to talk about, and that would be terrific. Yes, thank you. Thank you.
My name is Mira. Thank you so much for your talk. I wanted to ask you about how you see Western medicine and then more vernacular medicines playing into this healthcare outreach, and if you think there's a place for more traditional types of medicine in doing projects like this.
I mean, I think that there is a place for traditional medicine, you know, just as there is a place for traditional medicine in this country. I mean, I've never had crystals placed over my body, but people swear by them here. It's interesting that often people will suggest that traditional medicine sort of only takes place in these in developing countries, or often. But I really, if you look around at the plethora of options for us, non-traditional, it's quite wide. I do think there's a place, and I see it used all the time. I think, unfortunately, that some of these traditional options have been born of a dearth of medical services. So if you ask anybody, obviously I've seen plenty of people who needed to have antibiotics who got leaves instead and didn't fare very well. And I'm sort of making your question perhaps more complicated than it needs to be. But that's obviously not a great place for traditional medicine when there's effective therapies that should, because we should have high standards, be delivered. However, I've seen, wonderful and thoughtful versions of traditional medicine around some things, where they augment, or they're around listening, or they give people confidence. But I think in a way they're kind of complementary, as they are here. I do know of one or two people that are in my life who've decided to eschew any kind of conventional medical therapy around cancer and have gone instead to Switzerland for herbs. That neither of them are living. Now, it doesn't mean that doesn't work for some people. I just think that it's important for us to make sure that the traditional is not seen as a good option, a comparable option, if indeed there are therapies that are available. Does that make sense a little bit? Yeah, but lovely versions of traditional medicine that I've seen, but I don't want it to be one standard for poor people and one standard for us. Yes.
Hi, my name is Elza. Thank you so much for your talk. I think I found it very inspiring. During our time here, we're studying hotspots, and our hotspot is East Africa. And we found in our research that there's a lot of mobility in the population. And my question is, how do you deliver healthcare to mobile populations when the community is often torn apart? And so community workers may not be able to reach these mobile populations?
Yeah, that's a great question. We've worked with mobile populations, particularly in Haiti after the earthquake. So you had a huge urban population that went and often ended up in rural areas. I think it's difficult to do. I would say that we have to apply the same kinds of standards. At least we have to have this ambition to apply the same standards that we would here to follow a mobile population, people who leave and go to new cities and everything else, meaning we have to employ technology. And there are ways now that you can map and find populations. And if you actually, there are cheap and open source electronic medical records, for example, that you can use. And if somebody leaves, then you can track them. And I'm sure that, people migrating are usually doing so, particularly in East Africa, I believe, because of some hardship or need to get to a place where they can either earn more money or a relative has died and they have to go and replace them in some way. But I would say that if we could apply high standards around technology for helping to track, and we've done it a little bit with some of the populations in which we're working, that would be one way to do it. It's difficult though, because people often don't make plans to move necessarily. They up and go. But I would use some of the technologies that we would use here. Obviously, working with a public sector. If people are sick, they're going to register at a clinic, and then there's one overarching system that can help. And it might seem like a lot for, Burundi, for example, to get that going. But I do think that should be the standard. I'm interested, Dr. Penn. What do you think around something like that?
That's a tough question. I think you've got more practical experience. I have more inner thinking experience, but I think you have some practical experience with that. But it is a problem, and one of the concerns has been trying to do research to detect what are the best ways and the most effective ways to reach out. And I think one of those is, and it brings to mind that study that was looking at pathways of HIV transmission, where studying the pathways to determine the pathways and the repetitiveness of the mobile nature of the population can sometimes help, because if you get their patterns down and at least have them build in their stops at certain areas, that can help some. But it is tough. It's not like going next door, going a couple of blocks down the street, get your health care when you're moving, especially if it's because of economic and economic reasons. livelihood reasons can be very tough.
Yeah.
And I also liked your response to the complementary medicine bit. I think that's a very important question. Has a lot of
Yeah. Yeah.
implications.
Yeah. Do you have anything to add to that?
Just that I think back to long before most of you were thought of, but I remember when I was in my residency. I don't know if you remember, it was in, but Chad Green. There was a kid. I still remember his name. There's funny things that you remember, and this was in the late '60s. Phil Donahue did one of his shows on Chad Green, whose parents wanted to take him from Boston, and he had a type of leukemia that was still not having the cure rates that it has now. But his parents wanted to take him for, what is that peach pit thing, that apricot pit?
Yeah.
And the doctors in Boston were trying to keep him here to treat him, and parents insisted they had a right to use herbal treatments. And I'll never forgive Phil Donahue for doing a show and defending the parents, which I was young and opinionated then, but I still have the same opinion. I just would express it differently. But the kid died, and I just thought, you know, how many other people got the wrong message? Because we have to remember, because things are natural does not always mean they're good. There are a lot of natural poisons in, but on the other hand, there are things that can be very good. And as we learned more, we realized that grandma's herb treatments often had a basis that it just took years for science to catch up with.
Yeah.
But but understanding and knowing which ones have been tested, the National Cancer Institute actually set up a division within it to look at complementary and alternative medicines, because so often people were, and especially women, were receiving medications for treatments for their cancers, but were also taking herbal compounds, and the herbal compounds were blocking the effectiveness of the other medications. So it's important to not just assume you can do that and it caused no harm, but there's certainly times when when what grandma's cures were really, really valid.
Yeah.
So I think you put it, I think there is a place for complementary alternative medicines, but just understanding and knowing what's been tested, what's been proven, and what's unknown, as long as you don't think because it's natural, it makes it good. There are some, unfortunately, natural things that aren't.
Yes, yes. And
I
I
just
think,
admire all that you've done in moving, and I think just looking at the terrain where you are and being able to get and gaining the trust. Maybe you could say a little bit about gaining the trust of the population, because that's so important.
Sure. I mean, and I think part of that comes with gaining the trust of a population and a community comes from being there with them. It's part of the accompaniment piece. I think it's important to be with them, to learn their language, for example. At least make an attempt. Much harder to do in a place like Lesotho, than in Haiti, for example, or to learn Kenya or Rwanda. But that is very important, to be there with the community and to act on their behalf and make sure that you don't leave when things get tough. And I also think it also means to employ people in the community. That's a very big part of it. If the the situation there is very, very tough, and what people want are jobs. They often don't want handouts. Most of the time, I haven't seen people. They want dignified access to an education and then to jobs. And it's an issue when you've worked with a population for 25 years and you've watched these kids grow up. They've had access to medical care and vaccinations. They've been to school, and they're now in their 20s, and they're saying to us, "Where are the jobs?" I'm like, well, we're a healthcare organization, we don't do jobs. I mean, so then you have to think about bigger and bigger platforms and how to, accompany governments and make sure that there are other groups investing in a country like Haiti. But I think that getting the trust of a community comes with working with them, training and providing jobs. And also in medical care, it comes with providing results. I think that if there's a lot of rumors that can abound around things, and certainly I'm sure you've talked a lot about things like stigma. Once you actually provide treatment and people see that folks are getting better, it's much less stigmatized. So those kinds of things too certainly help in building building ties and trust with local communities, and then empowering the local district health officer to also make changes within his own clinics or the district that he feels is his purview. So it's a number of those things, and it often takes time. And we live in an age when people are really interested in almost instant results, and some of this stuff, it doesn't happen quickly. We've faced it with things like reforestation and that sort of thing. You can't force a tree to grow quickly. And if you plant a tree in a place where there's massive deforestation, but the reason it's deforested is that people need charcoal to cook their food, maybe their only meal a day, you can't eat raw, uncooked rice. So if you don't also provide an alternative, it doesn't matter how many trees you plant, or sometimes you can plant fruit-bearing trees. That helps because then people would prefer the fruit. But you have to be thinking of all of these things that are going to make a difference in a community. So, yes, right here.
Yeah, I loved your talk as well. So I have two questions. The first is, you mentioned that there are always these 10% or whatever percentage people that are the hardest to reach. So how do you learn the existence of this community in the age that we learn everything from internet, like their information? How do you know where they are, and how do you find out these communities? And the second is, you mentioned a lot of we provide medicines, but there is this controversy with intellectual property right of those pharmaceutical companies. They're doing these avant-garde research, but they're so expensive that even though we found them out, there are people dying in Africa. So is there any progress on this issue?
Yeah. How do you find this 10%? Because they're usually the most vulnerable, they're relatively easy to find. They're usually in the kinds of places in which you find vulnerable people. So in the inner city here, where you'd find them is in underfunded tower blocks and in areas in which there isn't a lot of subsidized housing and that sort of thing. It's in the poorest areas. You'd go to, it wouldn't be hard to do that. And actually Atul Gawande's article talks about that very well, about where they went. And now with all of the kinds of mapping that you can do, you can actually see, that's why he calls it hot spotters, because you can literally map an area and you can see, if you follow some of the clinic records, that as he did, I think something like a dozen of the most complex patients, in other words, the most costly patients to the system, in Medicare and Medicaid, came from the same apartment building. I don't remember what it was, I read it months ago, but in an inner city somewhere. You have 4 or 5 people coming from that same apartment building that have complications to do with, diabetes and amputations and terrible heart disease, all of that kind of thing. That can cost a system a lot of money. You can find that, particularly in this country. In the places in which we work in the developing world, again, they're going to be in the desperately very cut off rural areas. So often without great access to any kinds of services. Or again, they'll be in the inner city areas, often living in what is often known as slums. And it's not as though they're hiding amongst us, if you know what I mean. So that would be, I would say, not a difficult task to be able to sort of really find the most vulnerable people. And then the second around patents and that sort of thing, there's a very good literature and a good history to following some of this at the moment, including what happened in the HIV epidemic and what happened around the drugs that were obviously available, expensive, used here for plenty of people. I think at the time, early on, we're talking about $10,000 or $15,000 for a treatment, ART treatment. More as it started, but then sort of got to a level. A place like Brazil, they famously defied international patent laws and said, this is a public good for public health. We are not going to, let this happen. And they defied that convention. And, they got some heat for it, but in the end, it's important to, that countries, that they can decide to do those kinds of things to make sure that more people can be treated. On the other hand, which I think is probably more the meat of your question, how do you encourage companies to do the research and development if there's not going to be some sort of payoff. And I think that there are ways that we can do it. I mean, I think it would be just terrible to end up only creating drugs because we know that the drug company is going to make a profit. On the other hand, we have to be realistic. That's how the commerce and the business world is driven. So I think you form alliances. It's very good good examples of this with the groups like the Clinton Foundation who worked with drug companies, and they've done innovative things like agreed to purchase a large amount if they will get a good price. So, and you also, there's a great deal of work done on patents itself. I mean, our MDRT work in tuberculosis in Peru, again, there was no reason actually that those drugs that were so expensive then had to remain on patent. They were actually technically off patent. So then, you find ways, and I think this is the crucial part, you find ways to use your own talents and what interests you and your own skills to become if this interests you, to become, if the goal is to get equal access to people, then you find ways to make sure that you can advocate for that in all sorts of different ways along the road. So, that's the short answer. I think public goods for public health is a very important piece of how we must live today. And I think it's faced with all kinds of, we've spoken to foundations like the Gates Foundation. There's huge amounts of research done on drugs itself, making sure that when those drugs are discovered, that they are available to all kinds of different groups and populations. Very, very important. Yeah.
Hi, my name is Maya. I'd like to thank you for your talk. It was really inspiring. And your talk has helped me think about me doing this type of work. But when I think about doing this type of work, I think about my skin color and the fact that I'm white and privileged. And I just wanted to ask you how you've dealt with that in your work.
That's a fascinating question. If you zoom off into another part of the world, and for me, growing up in the countryside outside of London, as I did, and I had what I thought was a very worldly upbringing, and then went to Haiti at 18, it was extremely jarring to face all of those things. And I think in some ways, perhaps I was, because of my own privilege and because of my own entitledness, my thought was on, when I arrived there, my thought was on the fact that I knew I would never be able to sleep properly again if I didn't somehow contribute some of my own privilege to addressing some of this. It was not a sort of complicated equation. And I realized, and this was helped by meeting Paul Farmer, another white privileged person, that the best thing that I could do would be to apply the extraordinary standards that I had grown up with, taking for granted that certain things will happen, and try to apply those to a different group. And I think that this sort of steep gradient of inequality that we face every day, and it is, as you say, it's very complicated. Working in a place like Haiti that has such a really, I just say the only word I can think of is a rich and complex history that's utterly tied to the United States and to a colonial Europe. There's no, the countries in which we are working are all tied to a colonial empire in some way. There is a direct correlation with their poverty and that connection to empire. And realizing it was my job to understand as much of that as possible in order to be a better steward of higher standards, if you like, going forward. But now, our Haitian colleagues who are, Haitians who had it was the first Black Republic. I don't know how much you know about it, but it's an extraordinary and fantastic history. And they successfully had a slave revolt and became an independent republic, the first Black Republic. That they have been punished for that for the last 200 years. The direct connection between that and their impoverishment is important for us to know. So the other thing I would say is sort of understanding our role in that, I think will be the answer to how we address it. It's very, and so in Haiti today, for example, being very deferential to our Haitian colleagues in making sure that this is their organization, not my organization or our organization or a North American organization. And I think it's one of the reasons that we were able to be relatively, in the face of horrors, successful after the earthquake, or at least to address some of the issues right in front of us, is that the whole of Zambia-Lasanti is run by Haitians. And Haitian doctors and Haitian surgeons and Haitian nurses, we accompany them in some important way by helping get access to funds, by helping them get access to training up here, starting fellowships at Harvard, so that it's not all about people helping from here going down to Haiti, but really making sure that the fellowship goes back both ways. So it's a sort of a long answer, and it's very different in Malawi, whose independence came differently and only 30 years ago. It's a very different way of being there. But I think the most important part of this, and it's a really important question, is the obligation to understand the history and the role that that history has played in where a place is, or a country is, or a people are today. And so I think I'm never not aware of that as I go around. And I think it also goes from sort of, we all, as you've recognized, we are immensely privileged. And being able to sort of, it's not always a very humble, you can work with lots of people, and I'm talking self-critically of the NGO world, it's not a very humble bunch of people often. They're zooming into a country and tell them what they need. You have a very strong country like Rwanda who has been very clear. Haiti has 11,000 NGOs in its little tiny space. And maybe 2 are connected in some way to the fragile government. Democracy's only been there for 30 years. There's no systems in place. How you accompany that government, and you don't simply say, oh, Haitians are corrupt, oh, this is this. We have a tendency to oversimplify all of these issues. So, the connection to history, understanding the large-scale forces that are affecting where the country is, and really understanding your own role in it, and perhaps that role as an accompagnateur, to accompany others. This is what our Haitian colleagues asked us to call them, not community health workers, but accompagnateurs, because there's a length of time associated with it. I think is probably the best way. But do I feel satisfied in some way that I've cracked that? No, I don't. Sure.